in both chemistry and biology in 1989 from William Jewell College, then graduated from Mayo Clinic School of Medicine with a Doctor of Medicine degree in 1993. Today, Dr. Arnce brings over 25 years of clinical practice and emergency medicine experience to the classroom at KCU, having worked in numerous hospitals across 4 states. He has also fulfilled many leadership roles, such as being a founding partner and CEO of a physician staffing company, acting as the ED director of multiple ERs, leading medical staff in numerous institutions, as well as serving as medical director for fire departments, law enforcement, tactical teams, and multiple EMS services. So now, if you could please silence your mics and use the raise your hand function when necessary, that'd be greatly appreciated. Thank you, and take it away, Dr. Arnce.
Okay, I'm going to go ahead and, thanks, Haley. I'm going to go ahead and share my screen here. So Jeff asked me to talk today on something that I thought was fun and interesting. And so I'm going to talk to you today about point-of-care ultrasound. And this is something I'm pretty passionate about. We'll go through kind of what that is and how I use it in clinical practice. And it's kind of exploded. It's being used now by a number of different subspecialties, primary care, surgery, anesthesia, just a ton of folks in medicine. And I'll take you through some cases of things I've seen recently and kind of show you how it works. So basically, learning objectives, I'm going to tell you what point-of-care ultrasound is. We'll talk about the advantages and the disadvantages, the different applications, and the different types of ultrasound available. And then the thing that's cool about point-of-care ultrasound, there's a ton of FOMED, free open access medical education for ultrasound. So, you can pretty much self-educate. So why this talk? Like I said, point-of-care ultrasound is now hitting medicine, kind of like a tidal wave. There's an image over here of Dr. Tyler. This is him using a butterfly IQ while he's in Guatemala. This is Paulson, and he's next to the president of the American Academy of Family Practice. Yeah.
I'm sorry, your screen isn't showing. You need to
Well, that's a problem.
You need to put it in slideshow mode. It is showing.
Well, it is in slideshow mode.
Okay, there you go.
We good? Can you see me now?
Yes.
Okay. All right. Sorry about that. So, like I said, point-of-care ultrasound is just kind of becoming integrated in all parts of medicine. Here's a picture of our famous Dr. Tyler on one of his medical mission trips, and he's in Guatemala using this point-of-care ultrasound on a kid. This is the president of the American Academy of Family Practice next to Dr. Paulson, and he's holding a butterfly IQ. That's the type of ultrasound I have and carry with me in my bag. In the future, this is going to be used like a stethoscope. We don't put any central lines in the residency program now unless they're ultrasound guided. And it used to be that these things were super expensive, but now the tech and the price is getting to the point where it makes sense for about every practicing physician to have one. And there's a lot of research opportunities, just to throw a plug in for that. So I've been doing ultrasound since 1997. I came out of residency and was not trained in point-of-care ultrasound, but quickly picked it up. And I use it to look at hearts. I look at bellies. I look at musculoskeletal stuff. I do procedures with it. And I use it to diagnose undifferentiated shock. So this is kind of the evolution. Back in the the mid-90s, this is a picture of the machine that I used. As you can see, it's like kind of pushing around a small refrigerator, hardly portable. You had to change out the wands every time if you wanted a new image. This is what I use now. We having trouble?
Yeah, you're not quite advancing your slides.
He must have the slideshow on a different screen, so he's showing his PowerPoints. Yeah.
Yeah. Do this?
Yeah. Now we're
okay.
So well, what you just switched to is the right one.
Okay,
Now we're back to your original. Now we're just back to your slides without the slideshow being shown.
without the slideshow being shown. Okay, so you can see me, is that right?
You're perfect. Keep going.
Okay. All right. So basically, Jeff, is there a way to show a pointer on this though without doing the slideshow? Can you see my pointer, guys?
Yes.
Okay, good enough. All right, so the bottom line is they were big and expensive. This machine over here on the left costs about 50 grand. This one over here that I've got is $2,000. It'll do everything this one does and more, okay? And so that's what I mean by the price point getting in a ballpark area. So in the future, we're going to use this much like we do a stethoscope, okay? And when you use point-of-care ultrasound, it's done in the office or at bedside by the provider. It's not a formal study. Like if I order an ultrasound to be done by a radiologist, they're going to give me a lot of technical stuff. I'm asking specific questions. Is there pericardial effusion? Is there interperitoneal fluid, gallstones? Is there fluid around the kidney, et cetera? And I use it to aid in decision-making real time. And so the pros are many and the cons are few, but they're significant. The pros, I mean, it doesn't require any ionizing radiation. It's non-invasive. It's portable. It's quick. It's inexpensive. It actually has been shown statistically and by study to improve diagnostic accuracy, decrease cost of care, and time to diagnosis. The problem is, first of all, it's operator dependent. So obviously, when you're new at this, you don't get great images. And as you get better at getting the images, you become a better ultrasonographer. Your images get better. The other thing is ultrasound is limited by air and by fat. So if you have somebody that's very gassy or they've got a lot of adipose tissue, you don't get great images. So in terms of applications, I've already mentioned these pretty much, but I use it for a variety of things. I look at the heart and the abdominal structures with it. I look at some OB stuff with it. I actually use it to look at eyes, do central lines, and musculoskeletal things. So I'm going to start with the first thing that I learned to do just to kind of get you up to speed. This is a fast scan. This is the focused assessment with sonography for trauma. And so the idea is you take the ultrasound and you look within the abdomen for free peritoneal fluid. And in the presence of trauma, that's most likely blood. And so the idea is you identify early people that are having interperitoneal hemorrhage. And so there's several parts to the fast scan. This is the first view. This is the view of Morrison's pouch. This is the area between the liver and the kidney. And here's a negative scan, what this looks like. This is kidney here, liver here. And this is a positive scan. This dark line coming right between the liver and the kidney, that is Morrison's pouch. And that's the most dependent portion of the peritoneal cavity. So this is where fluid collects preferentially. So I look here to see if somebody's hemorrhaged. The next view would be a perisplenic view, or I look in the splenorenal recess, and here's spleen and here's kidney. And again, this is spleen, kidney. This dark stuff is all fluid. This coming down here is a rib shadow, to kind of show you kind of how it works. Here's a subxiphoid view of the heart. So here you have right ventricle, left ventricle, right atrium, left atrium. And this is the angle you use to get that. Here is the retrovesicular view. This is the bladder view. And so you look cross-sectionally and you look longitudinally and you get these images and you look for fluid around the bladder. And here, this dark right here is fluid on the outside of the bladder. So that'd be a positive scan. So let's see. Here's an actual case of mine. This is an 18-year-old. We'll go through some cases now. This is fun stuff. Here's an 18-year-old unrestrained driver in a rollover motor vehicle at highway speed, and he comes in with abdominal pain on the right and some right chest pain. And so here's a view of his right upper quadrant, basically the Morrison's pouch view. And this is normal. So again, liver, kidney here, and there's Gerada's fascia running on top of the kidney. And there's no fluid in the space that would be Morrison's pouch. Now, here's the kid that I did, okay? So here's his liver up to the upper left hand of the screen, and here's his kidney down to the lower right, and right here in the middle is this black line. That's fluid in Morrison's pouch. So this is important as a clinician because it lets me know that they're hemorrhaging internally. And so like when I was taking care of this patient, it was at a facility that did not have a surgeon. It was a small rural access hospital. So literally within 5 minutes of him getting to the ER, I could put the ultrasound on him, decide he's bleeding internally, and all I would have to do is just pick up the phone and call a trauma center and say, hey, I've got an 18-year-old MVC. He's got a positive fast scan. His vitals are stable, and they'll take that, and we can get him out of there because, you know, if I don't have a surgeon, there's no way I can fix this. And the alternative to this would be he would have to stay in my institution for a couple of hours, getting CT scans, getting him exposed to dye and radiation, and you know, it would delay his care. So that's the beauty of using the ultrasound for a fast scan. Let's see. Here's another case. This is a gang member. We have a thing down here in Joplin called Marion Days, and Rebecca will be very familiar with that, Dr. Bowden. But it's a homecoming for Vietnamese people who came over as refugees after the Vietnam conflict, and basically a lot of them relocated in Carthage, Missouri. Well, there's every year they have a homecoming. There's about 65,000 Vietnamese come from all over the country and come back home, and a small percentage of those are gang members. And so every now and then the Asian gangs will get into it. And this is a gentleman that I took care of. He was a 21-year-old gang member. He ended up coming in with a stab wound to the left anterior chest, and his pressure was 80/40. He had a heart rate of 125. His respiratory rate was 30. So, I mean, he was in bad shape. I got a quick chest X-ray. He had a hemopneumo, so he had blood in his chest on the left, and so I put a chest tube in him. But he didn't really respond like I wanted to. His blood pressure stayed down. His heart rate was up, and I even gave him some fluid. And so I did a quick fast scan, and here's what I found. So this is what a normal heart should look like. Again, right ventricle, left ventricle, right atrium, left atrium. And if you'll notice, this white around the heart is the pericardial sac, and there's no fluid in it. Now, this is this guy's heart. So here's his pericardial sac, this white outline. And here in the middle is his heart beating, and all this fluid in here is blood. So he's got a pericardial tamponade. And I actually had to do a pericardiocentesis, stick a needle in there and suck that out and call a cardiothoracic surgeon. They had to come in and basically open up his chest and do a pericardial window. He'd actually lacerated his ventricle. So again, kind of an interesting finding on a fast scan. And we'll move on here. Maybe. Come on. There we go. Okay. The other thing I use it for is undifferentiated shock. And this is a problem a lot of times in the ER. Somebody comes in, they can't really give you a good history. They're in shock. Their blood pressure's low. Their heart rate's high. You don't know why. And so there's this established thing, much like the fast scan, the fast exam I just showed you. It's called the RUSH protocol. And we look at basically, it's a glorified fast scan that also looks at the aorta and the lung windows. And over here is an image of the inferior vena cava. And the inferior vena cava is a great kind of resource to eyeball central venous pressure. So I can look at the vena cava and see if the vena cava is engorged or if it's normal in size. And if it's flat, then I know that they're hypovolemic. Now, I don't know the cause of the hypovolemia. They may have hemorrhage, or it could be, fluid loss, dehydration, etc. So here's the normal IVC. This is the IVC. This is the liver up here, and here's the right atrium here, and here's a flat one. See how it's different? I mean, this is obviously larger than this, and so this is a collapsed IVC. So this person, if they're in shock, it's because their volume's low, so you know right away you need to give them fluids. So here's this is a lady I saw recently in the ER. She was elderly. She came in, and she had a mild fever and some hypotension, and she'd passed out several times. So, you're like, well, what could be the cause? So I went ahead and threw the ultrasound on her. And again, this is a normal looking IVC here. And this is actual, I think, a student's video and me doing this ultrasound. So here we go. So if you look, this is liver. The IVC is right there in the middle where my finger is. And if you look at it, it's collapsed. Okay, there's the heart over here. Here's the IVC right here. And so see how that's kind of collapsed down. So I knew immediately that she's hypovolemic and hypovolemic because her volume was low. Okay, so that can be due to blood loss or dehydration, or sometimes medication might do that if it dilates the vascular beds. But great way to pick up causes of shock. Now here's another thing that I use the ultrasound for. This is more of an office type of thing, but I see this in the ER too. Over here on the left, that is MRSA, and I don't know if you guys know MRSA, but MRSA is a methicillin-resistant Staph aureus, and it's the scourge of the earth. It's resistant to multiple drugs. We see it in the ER all the time. It's a thing of primary care. It sees all the time, and so I hate these types of deals because you don't know if there's a bunch of pus under here that you need to drain or not. This is kind of indurated, meaning it feels hard, but it's not fluctuant, so it's not soft like there's a bunch of pus underneath. And so, back before ultrasound, I'd cut these things open, and half the time I'd cut into somebody, and there's no pus there. And, patients don't like that. You cut me open, there's nothing there. What's going on, And so here's this patient. This is a 54-year-old diabetic I saw. She had a history of MRSA. So I'm like, should I cut that open? Should I drain it? Can't really decide. Here's my ultrasound of that. And this is with my Butterfly IQ. And so this is your depth over here. And so you can see under the skin right here, this circle is a collection of fluid under the skin, right under this red stuff. So this is pus. So I was able to just, take a needle and stick right down into that and then cut down into it with an 11 blade and boom, there it is. So, again, another application of point-of-care ultrasound. Here's I have to give props to my wife. She's kind of like my guinea pig. And so you're going to see a lot of my wife's tendons and stuff on this lecture. But this is a friend of mine over here on the right. He's a gentleman who was playing basketball. He went up for a shot and felt a pop in his leg and was unable to walk. And, it didn't take rocket science for me to think that he had probably a ruptured Achilles. But here's the deal. He actually was a student at Southern at the time, and he had no health insurance. So in order to diagnose this normally, you would get an MRI, which is about $3,500, and then you'd send him to the orthopedic surgeon. So what I did, I just whipped out my ultrasound machine, plugged it into my phone, and so over here on the left is what normal Achilles tendon looks like. See this kind of fibrous stuff right here in the middle? That's my wife's Achilles, okay? And I'm going to come over here and click on this, or maybe not. Let's see. And this is Achilles here, but you see the disruption right here, okay? So he's got a torn Achilles tendon right here. This is all blood, and this is a disrupted tendon. So I was able to diagnose that and send it to an orthopedic surgeon. I just emailed, or I sent the picture of this text message to him on my phone, the orthopedic surgeon's phone, and said, hey, here's my buddy. He's got a ruptured Achilles. Can you take care of him? He scheduled him for surgery later in the week. The guy got his surgery without ever having to, get any imaging. So, reduced his costs significantly. All right, now let's see. Yeah, this is actually a great story. So this is the first ultrasound done by a KCU medical student on a patient, as far as I know, ever. Okay. So this is down at the community clinic, and this is a lady, Parker Adams actually did this ultrasound. This is a 47-year-old lady who came into the community clinic to establish care. Real nice lady. For those of you that don't know, the community clinic is a clinic here in Joplin that where we take care of the population that kind of falls through the cracks. They don't meet criteria for Medicare or Medicaid, but they're poor and don't have access to care. And so they can come down there and literally get care for free. And it's a great thing. It's a win-win. I mean, we go down there and we see them and get experience for our students, and the patients get good care. So this lady came in for establishment of care, and she had high blood pressure, and she said she had polycystic something. She couldn't remember what it was. but somebody in her family had polycystic something, and she didn't know if she had it or not. So anyway, Parker Adams saw her, and he's like, "Hey, could I take the ultrasound and check her and see if she's got polycystic kidney disease?" I'm like, "Sure, fine." And so here is up in the normal upper left-hand corner here. This is normal again. Liver here, kidney here. Pay particular note to the parenchyma of the kidney. And then this is the patient's kidney. If you look here, this is liver, and then all this stuff right over here. And as we go in and see all little cysts, so we were able to know and tell the patient, yes, you also have polycystic kidney disease, and that has implication on what kind of blood pressure medicines to take care of her. So great find medical students with the ultrasound. All right, this is one of my latest things I've been doing is I've been ultrasounding eyeballs. And so this is an ultrasound of an eyeball here, eyelid, anterior chamber, lens, vitreous, retina, and there's the optic sheath where the optic nerve is. So that's kind of cool. And so this is all vitreous in here. And so once again, my poor wife, here's her eyeball. In the COVID crisis, normally when I'm doing this in the ER, there's like a special opsite thing I put over the eye and then put the goop in. I just grabbed some saran wrap out of the kitchen cabinet and put it over her eye and then filled her eye socket with a bunch of goop. And so here's her eye, and you can kind of see, you know, her iris. You don't really see her lens very well. Here's her retina, and then here's her optic sheath. So pretty cool. Here's somebody who came in with central vision loss in the right eye. Their acuity was, and as usual, you know, they come in 3 days after the onset of symptoms for me to take care of them. And this is a detached retina. See this thing floating out here? We'll see it again. All this kind of, it looks kind of like a wormy deal in there. That's the detached retina. And I don't know if any of you have ever looked at the back of an eye, but it's really difficult sometimes to pick up a detached retina when you're looking with just an ophthalmoscope. So I can just throw the ultrasound on this person, and here's detached retina looking at me. So pretty cool. All right, here's another picture. This is chronic right knee pain in a guy who was playing some basketball. And so this is, again, this is my wife on the left. This is her femoral condyle coming down. So heads up here. Her feet are towards the left of the screen. This is her distal femur, her femoral condyle. And here is her patellar tendon coming down here. And here's an image of the guy that I saw. So here's his femoral condyle. And you see that black above it there? All that is fluid. And that he's got a joint effusion. So you know, if I want to, I could tap this. But so he's got a joint effusion, and I can follow this and actually follow a needle into that if I want to drain some of that fluid out. So next I've got a gallbladder. This is a female came in with right upper quadrant pain after eating greasy food. And here's an image of her ultrasound that I did. And of course, here's her gallbladder here. This is a big stone in the neck of her gallbladder. So she actually had, this was impacted. So she has cholecystitis. And I put this thing in to kind of show, this picture in to kind of show you some of the physics of the ultrasound. So the ultrasound's coming from the top of the screen. And so basically anything that's hard that bounces the sound wave off throws what's called an acoustic shadow. So this is a gallstone. It lights up on the front side, and you don't see anything behind it because the sound wave's all bouncing back towards the surface. And this is the gallbladder over here, and this is sludge in the gallbladder. So again, something else I can just do at bedside. Here's another case I saw recently. This is a 22-year-old gentleman. He had MR. He lived in a group home, and he came in just kind of almost beside himself. They thought he had some pain, but he was non-communicative, couldn't really say, you know, what was hurting. And I was reading through his chart, and he had a history of some kidney issues. So I thought, I'll go ahead and just throw the ultrasound on him. So here's normal anatomy over here: renal pelvis, the renal cortex, carotid fascia, medulla, and the calyces. This was his image, okay? So he's got massive hydronephrosis. All this is fluid in the collecting system, and he's got a huge ureter right here, okay? So he's got, he could have a renal calculus that's blocking the ureter, or it could be some sort of, congenital anatomic thing that's been exacerbated, but he's having pain because he's got renal colic. His collecting system's backed up, and his parenchyma, his cortex, is just this right here. This thin piece right in here is renal cortex, and that's it. So, and again, a very quick diagnosis on a difficult patient. So I'm going to talk a little bit here about belly pain and aortas. This is a guy that I saw. This has been years ago, and I was sitting there at the desk. He came in, and he was a kind of a salt-of-the-earth guy, a farmer. He says, hey, I hurt my back. I was lifting a mower and putting it up in the back of my pickup truck, and now my back hurts. And so I went in there and kind of looked him over, and I'm like, yeah, it hurts when I push on him. He's got degenerative disc disease. I got an x-ray. It showed a bunch of arthritis. So I'm like, okay, fine, degenerative disc disease. So I sit down, and I'm writing his discharge up. He stands up to go out, and he gets diaphoretic and almost passes out. I'm like, uh-oh. So I go truck it in there, lay him down, and I throw my ultrasound on his belly. And I'll show you normal over here, and then we'll look at his scan. So here's normal. This is vertebral body here. This is the aorta, and this is the IVC. Here was this guy's aorta, okay? So he had a big aneurysm, and actually he had a retroperitoneal leak out of it. His aneurysm had ruptured and was leaking retroperitoneally. So this guy that I almost sent home with some non-steroidal medicine basically ended up going to the operating room and opened up for a leaking abdominal aortic aneurysm. So, yeah, it happens. Okay, here's another guy that I saw. I was working a night shift. It's like 2, 3 in the morning, and they're bringing this guy through. He's a direct admit, and that's always music to my ears in the ER because it means I don't have to see him. But the medic's like, hey, doc, this guy doesn't look good. Could you take a look at him? And it's kind of like biting a cookie and putting it back on the plate. Once you're in as a doc, you're in for a penny, in for a pound. And I'm like, oh, okay, fine. What are you going to do? You're going to do the right thing for the patient. So I'm like, roll him over here. I'll take a look at him. So here's the story. This guy was 64 years old and had been at an outlying facility for the past 3 days on a heparin drip, admitted to a cardiologist for unstable angina. Okay, so they thought he had narrowed coronary arteries causing his chest pain, and they were giving him blood thinner. Okay, so I throw the ultrasound on him, and here's his aorta. Here's his vertebra right here, his aorta here, his IVC over here. See this line right here in the middle of the aorta? That is not normal, folks. And so this is longitudinal view on him. He has an aortic dissection. So this guy has been laying in the ICU at some other hospital for the last 3 days, getting blood thinner, and his aorta is torn. He's got a dissection. He's got an intimal flap. And so I called this was probably 10, 15 years ago. I called the cardiologist on the phone. You can imagine how this conversation went. Hey, this Dr. Arnce, your guy here, they stopped in the ER rather than direct admit him because he's sick, and he's got an aortic dissection. And of course, the cardiologist is like, well, how do you know he's got an aortic dissection? I'm like, I'm looking at it on the ultrasound, dude. And so anyway, he's like, well, I don't believe you. So I got the ultrasound tech to come in. That's before they believed that doctors could actually use an ultrasound machine. And they're like, sure enough, here's this dissection. So this guy goes off to surgery after having his heparin reversed. Okay, so let's see. Here we go. I just wanted to briefly talk about the different types of machines. So this machine is the one we have in the ER at Freeman. That's what we use in the residency. When we bought this, it was about 60 grand. This now sells for $9,000. Okay, here's a butterfly. This is what I have. You can buy that for $2,000. It plugs into your phone. This is a GE, this is a Philips Lumify, very similar to the butterfly. It sells for about 8 grand. And we actually have some of these, but they're old versions. This is the GE V-Scan. There's some up on the North Campus, some on the South Campus. They are not capable of looking at musculoskeletal stuff. It has to do with the frequency they're at. They're abdominal probes, but they're still usable and good. And then lastly, what I'd like to say is this is an easy thing to do. This is the first year military medicine class. That's Dr. Stewart. He's not in the first year military medicine class, but he actually teaches it. And so anyway, this is the first year class. We actually spent 15 minutes on how to do this. And here are our students at KCU doing point-of-care ultrasound. So this is a GEV scan, and this is a view of the liver and the kidney there. I'm sorry, that's a spleen. So spleen and kidney. And then down here is a subxiphoid view of the heart. And these are first-year medical students after 15 minutes of education on ultrasound. So I'm passionate about this. There have been maybe 3 things in medicine over the last 30 years that have changed my life. One was the Haemophilus influenza vaccine. We had kids that would come in and they'd have Haemophilus meningitis and terrible stuff. And after the vaccine, that's almost dried up and gone away. The next is BiPAP. That's positive pressure ventilation without having to intubate somebody. And the last thing that's dramatically impacted my world has been the ultrasound. And I'll tell you, the sky's the limit. These kids are passionate about ultrasound, and they're pushing me to just kind of further my skills. And right now I'm dabbling a lot in musculoskeletal, looking at rotator cuffs and stuff, things I never imagined I'd be doing. So with that said, I'll shut down here, and I apologize for the technical difficulties, but I'm happy to answer any questions.
Okay, let's thank our speaker. And nice. And we'll take questions now.
Hey, Bob.
Yeah.
It's Marcus here.
Hey, Marcus.
Thank you. Good seeing you, my man. I was really impressed with the slide example that you showed regarding the kidney issues. I actually suffered from that exact same condition. And as you were discussing it, I was 21 years old at the time. I would have loved to have seen what was going on with me, because I could feel the pressure build up. And in my ignorance, I thought I was suffering from some kind of back pain, and I would have my brother walk on my back. And I actually received some relief from that. Mm-hmm. And it was from a congenital birth defect. Yeah. But it just took me back to that time, and to see the amount of technology that was used, that could have been used, that could have aided me. One point that I wanted to make is that the original physician that I went to, he's real like, it's this, and other thing. And he really didn't take any time to really look into my case, even though the ultrasound was not around at that time, or at least not in the way that you use it. Mm-hmm. It took a registered nurse who just took the time to go in a little bit more deeper. She referred me to a specialist who put me on some kind of barium solution to identify what was going on, sent me through the x-ray, and just like that, he was able to catch it. And it was exactly the way that you had described it. I just wish I was not so old, that I was born a little bit late, and that technology could have been used. Would have saved me a ton of anxiety.
It's interesting you mentioned that, Marcus, because one of the things that's beautiful about this, like if you have somebody that's got a chronic problem, like chronic kidney stones or whatever, what has happened recently is, because of the medical legal thing, anytime that person shows up in the ER, they get a CAT scan. So, I'll have patients that might have 30 CAT scans, and the chances of you getting cancer after getting lit up that many times are pretty high. But if I have an ultrasound, I can just take an ultrasound and show they have hydronephrosis, and I know what's going on right away. And the other thing that's interesting that you mentioned, it has to do with the interaction with the physician. The nice thing is, it's very, it really improves patient satisfaction, because I can show the patient real time what's going on, and they really love that feedback. And I'm more in the room with them. And even now, think about it. When you have a study, the X-ray tech comes in, does their job. They don't really tell you what's going on. They say, well, the doctor will have to read it or whatever. But I can sit there and do it and show it to them, and really positive feedback. Yeah,
it is. It really is. Thank you, Bob.
Dennis Wolf has his hand up.
Okay, thanks. I really enjoyed that, and your comment about the opportunity to give on-the-spot feedback I thought was right on the money, at least from my perspective when I've had anything done. I have two quick questions for you. Number one is, have you made mistakes? And number two is, do you ever use point-of-care things like the iStat or whatever to get electrolytes?
Yeah. So have I made mistakes? Yes, of course. All the time, probably every shift I work, I make at least one, but what I would say is you have to use it just like you use a stethoscope. So like if I'm listening to somebody and I don't hear good heart sounds, I just say, heart sounds distant. I can't really make out, S1, S2 or whatever. If you have an ultrasound image that's equivocal, I don't put any weight in it, So if I can image the structures and see them to my satisfaction, that's one thing. But if I can't, I'm not going to make a supposition. And so I'll go to a different test if I need to image. And so, that's, and the other thing is we limit kind of what we do. So like when I do an ultrasound of a kidney, like if Marcus came in and I was worried about his kidney, I would comment about, is there hydronephrosis or not? I'm not going to sit there and measure the collecting system or the ureter or anything like that. That's too far beyond the scope of what I'm trying to do. Secondly, the iStat, I use the iStat a lot. As a matter of fact, I'm sorry to say I coded a 2-year-old last week, and it was an abuse case. And so in the process of getting the blood, anytime we have a code, I run it through an iStat so I can get electrolytes and hemoglobin, hematocrit, and creatinine immediately. And in patients that are very ill or tenuous that I want to send to the CT scanner, I get a POC, a point-of-care creatinine right away, and I get it back within a minute. And then so I can get a blood gas, I can get electrolytes, I can get a creatinine, and I can get a CBC, all point-of-care on the iStat.
Beautiful. George, you have your hand up.
Yes. Hi. It's excellent presentation. Very good. Good example. I do have a question. Ultrasound has color mode, and did you ever use a color mode? And can you give me an example of color modes you been used on, please?
Yeah. So a lot of times when I'm doing my ultrasound does have a color mode. And so the color mode, it'll show blue and red. And the idea is you can distinguish between arteries and veins. Whether it's blue or red really has to do with the flow related to the ultrasound. So you have to kind of know what you're looking at. But in general, this is always true. When you're looking at vessels, veins collapse and arteries don't. So I can tell what's an artery and what's a vein. But a lot of times I'll use the color flow if I'm looking to put in a central line or something like that. And it helps me to see, am I in an artery? Am I in a vein? So yeah, I use it quite a bit. There's also M mode, so you can do some stuff with that. I don't do that a lot. That's like I don't know if you ever heard an ultrasound, but like if you get an ultrasound, a lot of times they'll check flow and stuff. And I don't use that as much, but I do use color flow.
Okay, thank you.
Mm-hmm.
Any other questions?
So everybody needs one. Yeah, Baki.
Baki's got a question.
Hi, Dr. Arnce. Well, thank you. I see that you're really passionate about that. Is this machine, the ultrasound, very portable, can be used animal research?
Yeah, absolutely. Absolutely. Matter of fact, I know some vets that have them.
That's a great question and a great answer. I'd just make a quick comment here that This is a perfect example of how basic research and technology is really what drives innovation in medicine, and the need for such a thing is clear to me after seeing your presentation, Dr. Arnce. My goodness, what physician would want to be without one of these things?
You know, it's interesting. I have been doing some moonlighting recently up at a little small hospital in Nevada, Missouri. And so most of the time I'm a heavy hitter, like a level 1 type of guy. And so I really have everybody in-house. You know, if I want an ultrasound, if I want an MRI, if I want a CT scan, I can get that. But where this has great application is like if you go out of the country, like, you know, with Dr. Desai and Dr. Tyler, or if you're at a small institution that doesn't have ultrasound available 24/7, I was up there the other day and the family practice docs got one in their pocket. And we had a conversation. And so, you know, she does a lot of OB. She can do, you know, well checks on babies and stuff just really easily, and, you know, uses it a lot just in the general practice of medicine in a rural setting.
Thank you. George, you've raised your hand again.
Yes, I did. I have a question about the GEV scanner.
Yeah.
You said something that you cannot use it for muscles because of the depth. Did you say that?
Yeah. So here's the thing, and I should have left the slides in on physics, but so the ultrasound. Here's the way it works: the higher the frequency, the shorter the wavelength. Okay, everybody remember that from physics. Okay, yeah. So the higher frequency sound waves give greater resolution, but they have shorter depth of penetration into tissue because the wavelength is less. Okay, the ultrasound that I have, the way you get different studies is it alters the frequency and therefore the wavelength. And so the GEV scans that we have at the school on the North Campus, and we have a couple of them on the South Campus, the minimum depth that they can see is 6 centimeters. So they can view from 6 to 20 centimeters in depth, but they can't go any more shallow because they're restricted by the wavelength. Okay,
I do have.
Yeah.
Yes, I have. I'm just asking a question. Maybe I hope I'm not being. You know, if you used, can you use? Maybe that's. I don't know if that's a good logical example. Like saline bag, and put it on the shoulder or something to utilize that distance?
Yeah, that's actually a great question, and it's very applicable. You could throw a saline bag on. The other thing I've done, actually, we've been playing around with these a lot down in Joplin, just seeing what they could do, and, you know, are they applicable for, you know, OM and stuff like that. And so one of the things that we have done is using a water bath. And so, like, I can put, like, if I put the ultrasound, if I put one of these old V scans on somebody's finger, I can't see anything because, you know, it's way too shallow what I'm trying to image. But I can put their hand in a basin of water and stick the ultrasound in there, and I get a beautiful image of their finger because I'm transmitting through water, and I get the distance I want. And that's much better when I'm looking at the eye because I'm filling the eye socket up with ultrasound gel to give me a longer distance to the stuff I want to image. So, yeah, you can do that.
Saline back. Okay, thank you.
Any more questions for Dr. Arnce? Okay, let's thank our speaker one more time.
Thanks for your attention. Sorry for the technical difficulties.